So just read it and try to answer the questions. I will be glad if you are active. So who is ready to give answers and comments? I shall help without any doubts. Is it difficult, colleagues? Let me help you for this clinical case. So we know about the main diagnosis. It is coronary artery disease. Previously, it was stable stenocardia, but it is declared that it is worsening. So we can see the signs of one of the acute form of coronary artery disease. Why is it so? Increasing external angina with shortness of breath and with hypertension. So it is acute coronary syndrome. We can't estimate that it is myocardial infarction. We have no details. Acute coronary syndrome with hypertension and with possible previous heart failure because of ankle edema. This is the answer to the first question about sciences and syndromes. So sciences are external angina, dyspnea, hypertension, ankle edema. Syndromes, acute coronary syndrome and acute or chronic heart failure or exacerbation of the heart failure. Why heart failure? Once again, shortness of breath, postural hypertension, and ankle edema. What risk factors? Risk factors are the following. Previous diagnosis of coronary artery disease in the form of stable angina. Moreover, his heredity, early death of his both parents, father from stroke, and his mother from vessel, sorry, yes, from her complications of diabetes. And we remember that the main of them are vessel connected. Oh, moreover, we know about, we know about his vital parameters. So his blood pressure is normal, but at the low normal position. We are to monitoring it, and then we can speak about that he is ready to cardiogenic shock. But now he is far from cardiogenic shock. It is normal for his heart failure. He is tachycardic with dyspnea, afebrile, and with clear consciousness. It is good. it helps us to verify the heart failure exacerbation that we estimated previously. What investigations do we think essential? First of all, it is necessary to exclude acute myocardial infarction. That's why we start with after direct exam, in which we are to be sure that the rhythm is not like HELOP, typical for acute heart failure. We are to estimate the level of cardiac markers of myocardial infarction and heart failure. For myocardial infarction, it is troponin, myoglobin, creatine phosphokinase of the cardiac fraction, as you remember, 3 typical biomarkers for acute myocardial infarction. Let me repeat them to you. Troponin, myoglobin, creatine phosphokinase of the cardiac fraction. To tell the truth, the appearance is the following: myoglobin together with the creatine phosphokinase and then troponin. That's why it is necessary to use maybe all of them. And brain natriuretic peptide, a marker of heart failure, also must be done. ECG and echocardiography. We are interested in the patient's rhythm and in the fraction of ejection from the left ventricle, zones of akinesia, hypokinesia, and all other possible problems in the heart, which may be visualized. We also need chemical blood tests to know the level of function of kidneys and liver. In case of coronarography, will be necessary to perform. This is the answer to this question, number 3. Any questions to me, colleagues? No, let's go on. It is necessary to train because at exam, due to nervous situation, due to short of time, you will be limited in time. It is necessary to be sure that you are able to solve the clinical case in a quick style. We have done such clinical cases. Maybe somebody wants to give the answers, please. Oh, well, Monday is not the day of activity, okay. So the moderate age gentleman with swelling on his face, at examination, pale skin and swelling of feet and legs also, except face, give us edema sign. Then we can see hypertension, tachycardia, dyspnea. At auscultation, we can't auscultate in a proper way low parts of both lungs, but the patient is a febrile, and because of peripheral edema, we can suspect not pneumonia, but other problems concerning edema. And at laboratory tests, we can see deficit of albumin, excess amount of total cholesterol, at urine test, severe proteinuria of nephrotic level. So, according to the combination of all these sciences, we can suspect nephrotic syndrome because of proteinuria of nephrotic level and severe edema, not only peripheral, but possible effusion in pleural cavity. That's why we can't auscultate his lungs. Uh, which investigations, the risk factors are not indicated here, but we know that very often it may be either the history of streptococcal infective process or other infections, even virus hepatitis B or C, like extraviral problems with kidney damage, and it may be neoplastic syndrome with the formation of nephrotic syndrome also. Investigations that are necessary to be done to be sure that it is nephrotic syndrome are the following. We need common blood count, common urinary test, biochemical blood test to see the level of creatinine, glucose, electrolytes, liver function. It is necessary to perform chest X-ray to be sure that there is liquid in pleuritic cavities. And to see that it is not pneumonia. And later we can monitoring the amount of liquor in pleural cavity with the help of ultrasound, not to perform X-ray in a day. We also need immunological tests like C-reactive protein, immunoglobulins for streptococcus. And according to the possibility of cancer nephrotic syndrome etiology, or we can perform cancer biomarkers test. This is the plan of investigations. Colleagues, do you have any questions? No? Well, I shall use this clinical case to identify for you cancer biomarkers. Next step, without any doubts, you will speak more about cancer biological markers, but today I would like to say you that in reality nowadays there are two of them, for liver cancer and for the cancer of prostatic gland only. All other biological markers for cancer can monitoring the duration of the cancer situation according to the treatment or without treatment, but has no diagnostics sense except these two of liver cancer and of the cancer of prostatic gland. It is necessary to know, and in most countries since 40 years old, these two biomarkers of cancers are included in annual investigation for the persons, not for the patients. For possible early diagnostics. The diagnostics value of these two biological markers is comparable with X-ray of mammary glands, for example. So it is of rather high sensitivity. Let's look for the next clinical case. Just read it, please. So colleagues, maybe somebody wants to give answers to these questions. Okay, so here we can see a moderate-aged gentleman, and this is a sudden and I suppose the first episode of the chest pain. So according to the first attack, according to his heredity and that his father died at very early age from cardiovascular catastrophe, it is necessary to hospitalize this patient at emergency department and to perform investigations. We can constatate a suspicion of acute coronary syndrome because of severe wheezing chest pain together with dyspnea. We can see that respiratory rate is according to the dyspnea. He is hypertensive and tachycardic, but this may be accompanied the chest pain. So we can't speak about hypertension, but this is a condition of hypertension, not a hypertension as a disease. Necrotic cardiac markers must be checked simultaneously. As I have said in previous clinical case, they are myoglobin, creatine phosphokinase of cardiac fraction, and troponin. Echocardiography together with ECG must be done. We shall see the rhythm, the cardiac rhythm, the output of from the left ventricle, the peculiarities of the structures of the heart. Full biochemical test must be done because very often the first episode is associated of necessity of coronarography. And with the help of creatinine in blood, we shall calculate GFR and make a decision about the possibility of providing of Röntgen contrast investigation. Any questions? No. Okay. If you aren't against, let's restart simultaneously. I shall copy your attendance. Let's restart simultaneously. We will be able to discuss 5-6 clinical cases and finish today's class. I'll give you self-training, or it was sent to you. I suppose if anybody wants to give comments, you are welcome. It is not necessary to ask. Just switch on the microphone and you may speak.
So we can see the signs,
Mm-hmm.
edema of the face and legs,
Good.
tonsillitis,
Mm-hmm.
nephrotic level of proteinuria,
Good.
decreased albumin level,
Decreased, yes. Mm-hmm.
Yeah, that's all.
Mm-hmm.
So it is nephrotic syndrome.
You're quite right. It is nephrotic syndrome. What is the main risk factor for nephrotic syndrome in this age?
Antibiotics is not given to the patient.
Yes, because it is streptococcus infections very often, tonsillitis, yes. And please, the plan of investigations, Jan. Mm-hmm.
Ultrasound to check the level of the edema.
Mm-hmm.
So we need to check the level of the cholesterol, creatinine, and albumin.
Mm-hmm.
Urinary tests and blood pressure.
Yes, you're quite right. We can monitoring the blood pressure because sometimes we can see mixed syndrome together, nephrotic and nephritic syndrome. What is about immunological test? Are you interested in antibodies to streptococcus?
Yes.
Yes, it will open the question about etiology. Thank you very much. It was a very nice comment. Please, next clinical case. If you remember, we have done a similar clinical case. It is about asthma attack and very close to asthma status. The patient is tachycardic. The dyspnea is severe. Chest is already inflated. And there are zones with very weak breathing. Saturation is rather low. No efficacy of salbutamol, but the necessity of bronchodilators are very high. So it is the status of asthma. The patient must be brought to emergency unit or a unit of intensive treatment. It is severe bronchoobstructive syndrome, severe respiratory failure. And the risk factor is bad treatment of asthma. Just a minute, colleagues. Далее, Анатолий Александрович. Здрасте. Да, у меня. Мгм. Хорошо, хорошо. Мгм. Мгм. Хорошо, сейчас пришлю. Сейчас пришлю. Хорошо. Мгм. Хорошо. Well, colleagues, please, such clinical cases we have done a lot. Please try. Maybe you will be lucky by yourself. If it is necessary, I'll help you. Is it, colleagues? Is it difficult? Well, fever, weakness, these are signs of intoxication. So we have the syndrome of intoxication. Moreover, we have the syndrome of inflammation because of leukocytes enlargement, ESR enlargement, and we can identify that this is liver inflammation or with the cytolic syndrome. Tell me, please, which level of cytolysis does this patient have?
severe?
Yes, it is high. It is high because it is more than 5, 6. So it is um, between sorry, between moderate and high levels. Okay. Any questions about this clinical case? Why is it so difficult for you, colleagues? Colleagues, why is it so difficult to answer? I suppose it is not so difficult, by the way. Okay, let's try next clinical case. So, colleagues, here we can see anemia. Let's discuss. So, a moderate-aged female has a medical history of chronic gastritis. In case of chronic gastritis, we can suspect either ferrum deficit or B12 deficit anemia. It depends upon bleeding or atrophic components. Bleeding more often in case of ulcers, not in case of gastritis. Typical signs of anemia together with this one, together with tachycardia and dyspnea. Why tachycardia and dyspnea are typical for anemia? Because these are compensative mechanisms. Moreover, we can see that spleen is enlarged, liver is not enlarged. And isolated enlargement in spleen is typical for B12 vitamin deficit anemia. So in the complete blood count, we can see decrease of hemoglobin. It is anemia together with erythrocyte decrease, but color index is normal. It is untypical for ferrum deficit. Anemia, moreover, we can see hyperchromia. It is typical for B12 vitamin deficit anemia. So we can constatate that this is the anemic syndrome, and the risk factor is chronic gastritis. we can suspect that it is atrophic gastritis. That's why deficit of B12 vitamin. That's why anemia. Any questions? Okay, let's go on. So typical clinical case with the signs of intoxication because of slight fever, weakness, leukocytes enlargement, ESR enlargement, and it is due to cytolic syndrome of low activity, but we can see that the risk factor is indicated. It is infection of hepatitis C virus because its RNA is identified as positive. Moreover, it is known from his medical history that it is a chronic disease, and now we can constatate the active phase of hepatitis, its replication, because we can identify RNA of this virus in blood. At the stage of integration, we can't see RNA. We shall see a lot of antibodies. The plan of investigation, we need all other parameters of liver function because the duration of the disease is prolonged. It is chronic and prolonged. We need to see the function of liver, the function of kidneys, ultrasound investigation of abdomen to see the presence of absence of ascites, the diameter of liver portal vein, and esophagoduodenoscopy to see the veins of stomach and esophagus. Another nephrotic syndrome here, but have a look, the blood pressure, oh, sorry, it is not, yes, it is. It is very close to nephrotic syndrome because of deficit of albumin, excess amount of cholesterol, and the patient is rather young, but the level of protein is not of nephrotic level. Maybe it is not collected was, so it is necessary to repeat this test. And we can see hypertension, though creatinine is normal. All the tests must be repeated because this is the case of coexisting of nephrotic and nephritic syndromes. We can see macrohematuria, hypertension, though we can see macrohematuria and bad level of erythrocytes in the macroscopic, I suppose, at microscopic investigation. I suppose that this clinical case must be corrected. I don't understand what is the correct answer. What is the mind of my assistant here? Okay. I suppose it's enough for kidneys and liver. Let's come back to cardiac problems. So what can we see here? colleagues, what you can suspect in this clinical case? The clinic of sudden retrosternal pain. Here we can see ECG. So let's look at the second lead. We have a prolonged line. The rhythm is sinus. RR interval is equal. P before each ventricle complex. But we can see ST segment elevation more than 2 millimeters in the first ended line. Deep negative T in the third one. Inversion of ST segment in thoracal lines. So these signs are typical for acute coronary syndrome. And according to the patient's medical history, it is a risk factor for myocardial infarction. We can suspect it and start with typical common profile of acute coronary syndrome or myocardial infarction investigation. So, cardiac biomarkers, myoglobin, creatine phosphokinase, troponin, complete blood count to see the level of the inflammation, to see that there is no bleeding, hematocrit and hemoglobin we are interested in. Echocardiography to see the ejection fraction. At this time, chemical test will be done with creatinine, liver enzymes, and we are ready for coronarography. Any questions, colleagues? No? Okay. Typical nephrotic syndrome is here. Let's not waste time for it. Here we are. As you can see, there are some types of clinical cases, and most of them are dedicated to liver, kidney problems. Here we can see cytolysis of moderate level, cholestasis because gamma-glutamine transpeptidase and alkylate phosphatase is enlarged also of moderate severity. Liver is enlarged. And intoxicative syndrome. Have a look. Risk factor is indicated. 3 months ago, the patient had appendectomy. Maybe it is a hospital infection. So B and C hepatitis viruses must be identified very often. Stomatological procedures, surgical procedures are associated with possible infections of hepatitis. Nowadays, it is less and less. 30 years ago, it was rather often. Another clinical case. So here you are. So colleagues, what can you say about this clinical case? Yes, you are welcome. From my point of view, it is better to start with the beginning, from the beginning. So it is cardiac problems without any doubts, with a patient of moderate age suffered from both coronary artery disease and arterial hypertension. So what do we have here looking at the standard second lead of a prolonged line? It is not sinus rhythm. We can't see P before each ventricle complex. Moreover, RR distance is different. Just compare it. It is enough to constatate waves. It is enough to constatate atrial fibrillation. We do not have an opportunity to calculate the speed of heart rate. We can't. That's why we need direct examination, blood pressure, heart rate, estimation of heart rate and pulse. If they are different more than in 10 beatings, we can constatate pulse deficit. It is necessary to perform coagulogram, and atrial fibrillation is an indication for antiarrhythmic treatment for anticoagulants. That's why we need the hemostasiogram, echocardiography to see the left ventricle effusion, and full biochemical test with liver and kidney functions because they will be necessary for initiation of the treatment. What are the main risk factors for rhythm disturbances? They are atrial hypertension and angina. These two, first of all, atrial hypertension. Though if we, sorry, colleagues, if we look, there are no evidence sciences of hypertrophy. It doesn't mean that the patient doesn't have hypertrophy. It may be estimated at echocardiography. Yes, at echocardiography. And proBNP or BNP, brain natriuretic peptide, must be checked together with troponin, by the way, to exclude the ischemic problems, necrotic problems, and heart failure. This is the answers to all these questions. Any questions to me, colleagues? No? Okay. Let's try this clinical case.
Liver failure.
You are quite right. Let's discuss what are the main signs of the syndrome of liver failure. Insomnia and weakness, without any doubts, they will give us the syndrome which is connected. It is better to give you tremor here also, because insomnia is a sign of liver encephalopathy. And liver encephalopathy is very close to liver insufficiency. The peculiarities of medical history, these are risk factors, the answer to the second question, but let's come back to the first one. Spiders on the skin, liver and spleen enlargement, they are enlarged together. And a lot of deficits are here. First of all, it is deficit of albumin. of prothrombin and cholinesterase, typical signs of liver insufficiency. Moreover, we can suspect hemoglobin is low, we can suspect bleeding. There is no other indicator for bleeding, but only because of low hemoglobin, we can suspect it. If hematocrit is added, we can be more sure and look for the source of bleeding. That's why in the plan of investigation, we shall include full complete blood count. You can see that the patient has also deficit in platelets. Then we shall perform ultrasound investigation or computed tomography of abdomen to see the diameter of vena porta, to see the presence of ascites, portal hypertension maybe together with liver insufficiency, and upper and low endoscopy to see the condition of veins. I mean stomach esophageal veins for upper endoscopy and rectal veins for lower endoscopy, because these are possible sources of bleeding. Varicose changed veins of these zones are the main sources of bleeding in the patient of liver insufficiency. To tell the truth here, we can suspect cirrhosis, but liver cirrhosis, but you are not asked about the diagnosis. You are asked about syndromes. So liver insufficiency, possible gastroenterological bleeding, and suspicion of portal hypertension. Suspicion on liver encephalopathy because of insomnia. Colleagues, any questions? Okay, good. Let's go on. Be attentive with this clinical case, though it may be it may seem to you that it is very simple. So, colleagues, what can we speak about? Let me help you. So, we can speak about pneumonia. Why? The following signs as febrile level of fever, chills, dyspnea, percussive and auscultative signs together with X-ray. These are the signs of the syndrome of pulmonary induration pulmonary inflammation. Respiratory failure. The level of dyspnea is severe, 32 a minute. And the syndrome of shock. Blood pressure is low. This is a pneumonia of high severity. And if we use CRB scale, CRB 65, we shall see that nothing is, yes, consciousness is clear, but blood pressure is low, 1 point, respiratory rate is too high, 2 point, the second point, 2 points. It is severe duration of pneumonia. The patient must be immediately hospitalized. The risk factor, well, it is the disease which is associated with infections. It may be either viral or bacterial. And we can see that yesterday the patient was very cold. So it is either cold or contact with sick persons, with patients. This is the main risk factors. Investigations, we need at emergency department complete blood count, the level of saturation of oxygen with the help of pulse oximetry, and it will be enough. All other procedures together with ECG will be fulfilled at reanimation unit, because this patient needs oxygenation at once. Any questions, colleagues? So this is the situation where you are to show your knowledges, especially about CRB scale. Well, another nephrotic syndrome. You can see the proteinuria of nephrotic level, deficit of albumin in blood, signs of inflammation, normal blood pressure, dyspnea because of possible fluid in pleural cavities. So X-ray must be added to all the plan we have discussed. Typical nephritic syndrome, without any doubts. With hypertension, macrohematuria, increased creatinine in blood, and not nephrotic level of proteinuria. Again, nephritic syndrome. But risk factor is another. You can see that the patient had lupus erythematosus in her medical history. And the risk factors are insulation and not controlling of her status of lupus erythematosus and the function of kidney. The same plan of investigation typical for nephritic syndrome. Must be fulfilled here. Just read this clinical case and I shall give you advices how to answer. So it is a planned visit to a general practitioner with the corresponding medical history. We can see bradycardiac patient with high blood pressure, hypertension. Bradycardia is not severe. It may be associated with beta blockers intake. They influence on the heart rate. We are interested in the enlarged creatinine. It is not enlarged severe, but in this case, we can calculate GFR because we have 3 tests in duration of some months. And at exam, it is necessary to calculate GFR, to estimate the stage of chronic kidney disease, and to say that it presents. It is not a nephritic syndrome, for example, though common urine test must be done, because anything may be. At this age, the main etiology of possible nephritic syndrome, if it is neoplastic problems. But here we suppose that it is generalized atherosclerosis with possible involvement of renal vessels. And if GFR allows, angiography may be performed or only ultrasound investigation of kidneys and kidney vessels. Okay, colleagues, a lot of clinical cases already are done, 30, there are 45 prepared. So you have your home task. I ask you to be attentive and try to fulfill it. I have marked your attendance. See you on Thursday at our Common ID class. Thank you for your attention. Goodbye, colleagues.
Thank you.
Goodbye.
Thank you.